So our ECG records the heart's electrical activity, or the voltage. This is also known as potential difference. And it records that across the heartbeat. So from this, we can get information about the heart's rate, rhythm, but important to note, an ECG does not tell us if the heart is actually beating. So for that, we need information about cardiac output, which we can do by palpating for a pulse, looking at our blood pressure and our end-tidal carbon dioxide if our patient is under GA. The parts of the ECG include the electrodes, which is the bits that are attached to the skin. Under anaesthesia, we usually use 3 to 4 electrodes, but in cardiology for diagnosis, they might use a lot more electrodes, so sort of 10 to 12. You then have the cables, which will connect your electrode to the machine, and then your display machine will produce the trace for you. So these are the placements of a 3-lead ECG, which is the ones we most commonly use in anaesthesia. So in England, we use the red, yellow, green system, where the red lead is connected to the right forelimb, the yellow is connected to the left forelimb, and the green is connected to the left hind limb. Sometimes you'll also have a black electrode in your kit, and that's just a ground electrode, which we usually connect to the right hind limb. Important to note, if you've got an American ECG system, the colours will be different, so just make sure you follow the instructions. These lead placements are correct for a diagnostic ECG, where your interpretation of your ECG means you need the right trace on leads 1, 2, and 3. Under anaesthesia, we're mainly monitoring sort of roughly the heart rate and for any rhythm changes. So we don't need the leads to be exactly correct. So what we can do is just place the ECG leads anywhere that's accessible on our patient that will create a triangle around the heart. So if, for example, if a patient is having forelimb surgery, it's not really practical to put a lead on this limb. So what we might do is put 1 on the other forelimb and then 2 on the hind limbs. Or if they're having bilateral forelimb surgery, we might place 2 on the hind limbs and then 1 on the nose, for example, just anywhere that's creating a triangle. The different types of electrodes we have, and most people will have crocodile clips, so little metal clips that you can place usually on the elbows and stifles, kind of somewhere with a little spare skin. Otherwise, you can get sticky electrode pads, which can be placed on hairless skin, so either paw pads, maybe the nose, or otherwise you need to clip the fur to place these. To get a good trace from our ECG, we need good contact between the electrode and the skin. The sticky ECG pads use conducting gel. Conducting gel is a salty gel. It contains a silver salt that's used in ECGs and defibrillators to get good electrical contact. It can be quite expensive, so an alternative would be to use lube or ultrasound gel, but because they're not as salty, they don't tend to conduct as well. Otherwise, you can use spirit, but it does tend to dry out under GA. And otherwise, you can use a hypodermic needle through the skin. So for example, if you've got crocodile clips, you can put a needle through a loose bit of skin and attach the clips to that. If you're doing that, it's really important that you're not moving the patient with the cables attached, because any drag or tension on that needle can cause trauma. So it's really only for when your patient is very still in surgery. So the electrodes are the part that's in contact with the patient. The leads are then the trace that's produced. So with this configuration, we get 3 standard leads and 3 augmented leads. So our 3 standard leads are lead 1, 2, and 3, which when placed in their normal placement round this cat that you can see, your lead 1 will be right 4 to left 4. And then your lead 2 will be right 4 to left hind, and lead 3 will be left 4 to left hind. Our diagnostic ECGs will then give us 3 more augmented leads. These aren't always present on an anaesthesia machine because we don't use them so much. But the machine essentially calculates an imaginary central terminal, so the other sort of the negative terminal is in the center of the heart, which is the difference between all the electrodes that you've got. And yeah, these are the leads it comes up with. So the trace the ECG produces is due to changes in a potential difference throughout the heart through the cycle of the heartbeat. So as the depolarization spreads from the sinoatrial node through the atria, as the atria depolarize towards the atrioventricular node, this will produce our P wave. As there's a little break while the depolarization is collected in the atrioventricular node, there'll be a flat line, which is our sort of P to Q flat line, which conducts slowly so that you don't get kind of simultaneous depolarization of the atrium ventricles. And during this time, you get no change in potential difference, so the line is flat. We then have our QRS complex, which is made up of depolarization of the ventricular septum and the ventricles, and then the end of ventricular depolarization as the wave spreads up the ventricles. And then you have the T wave, which is due to repolarization of the ventricles. The atria will repolarize, but it's a very small signal that's simultaneous with the QRS complex, so it's sort of overridden by the bigger signal from the ventricles. So sometimes we connect our ECGs and they're not nice to read. So there can be a few different problems with connecting our ECGs. So if you've connected everything and you've not gotten a trace, what might have happened is either your electrode has fallen off, so maybe your crocodile clip has come loose, or otherwise it has poor contact. So maybe your spirit's dried out or your conducting gel has dried out. It can also be if your ECG cable has actually come loose from the machine, so that's another thing to check. You might get a fuzzy ECG if your patient is moving, panting, shivering, or if you've got any electrical interference with your ECG. So for example, from surgical cautery devices. It can also happen with MRI signal as well. You can also get a fuzzy signal if you've got poor contact or if your patient has an arrhythmia. So it's important to rule out all those other causes and investigate if you might think you might have an arrhythmia. If you've connected your ECG and the complexes are either really, really tall, so you can't really see too much difference between them, or if they're really small and you can't really see them, what you can do is on your monitor, touch on the screen where it has the ECG trace, and it will bring up the settings. For that, to make the complexes bigger or smaller, you need to adjust the part that's called gain or sensitivity sometimes. If your trace is running really fast or really slow, you can slow down or speed up the trace by adjusting the speed, again, on the settings of the ECG. The default is usually 25 millimeters per second, but you can speed it up or slow it down, depending what you want to do. So for ECG interpretation under GA, we tend to use lead 2 for our most familiar complex shape. But of course, if we've placed our ECG leads in a kind of non-conventional position, then the lead is going to look different. So what we can do is flick between the leads, so either lead 1 or lead 3 might look more familiar to us. But if we put the leads upside down on the patient, so maybe we've put red and yellow on the hind feet and then the green on the forelimb, we might just see an upside down ECG. And it's important to sort of recognize where our leads might produce changes in our ECG so we can tell if it's normal or not. So these are the steps we usually go for go through to investigate sort of, is this rhythm normal or not? And if it's not normal, what might be the cause of these changes? So the first step is always looking at the heart rate. Is it normal, fast, or slow for that species? Having a look at the heart rhythm, is it regular or irregular? If we think we've got an irregular rhythm, does it follow a pattern, and so it's regularly irregular? Or does it not seem to follow a pattern at all, and it's irregularly irregular? And when we're saying whether a rhythm is regular, what we're looking at is the R wave. So the big, tall, spiky wave, is the distance between them equal or not equal? And then we look a bit deeper at the ECG, seeing, is there a P for every QRS complex? Is there a QRS complex for every P wave? And then is the QRS shape normal, spiky, or wide and bizarre? So any changes there. So then I'm going to go through a couple common rhythms with you guys, just so we can see what these might look like. So a sinus rhythm has a normal rate, rhythm, and complex shape. But just to remember that the ECG does not tell us if the heart is actually beating and that the patient has a cardiac output. So we might get this rhythm under GA, and it's hard for us to know, is our patient alive from this rhythm? So what we can do is feel for a pulse, check for our blood pressure. You can use a Doppler if you can't feel a pulse, and check our end-tidal carbon dioxide as well. If all of those are normal, then we're doing great, our patient is stable. If we can't feel a pulse, this could be pulseless electrical activity, which is the most common rhythm in cardiopulmonary arrest in our veterinary species, and so this would need CPR. So it's really important that we can figure out, is our patient alive, even if we have a sinus rhythm. Another common arrhythmia under GA is a sinus arrhythmia. So this has a slower or a normal rate. It's regularly irregular, so it tends to run in kind of short bits of a faster rhythm and then a slower rhythm. So for example, the ECG at the top has those two complexes with a longer RR interval and then three close together. This rhythm has a P for every QRS and a QRS for every P and a normal QRS complex shape. You get the sort of variation in heart rate due to changes in intrathoracic pressure through the respiratory cycle. So in a spontaneously ventilating patient, as the patient inhales, you'll have a decrease in intrathoracic pressure, which draws blood into the heart, and then in the next exhalation, you'll get a slower heart rate. And the reverse will happen during exhalation. This rhythm is particularly associated with high vagal tone. So this might happen in very fit patients, brachycephalic patients, patients with gastrointestinal disease or respiratory disease, but is commonly under GA drug related. So things like opioids or alpha-2 agonists will cause this rhythm. Whether you need to treat a sinus arrhythmia depends on whether your patient is hypotensive and bradycardic with it. So if your patient is, say, has a rate of 36 to 40, but their blood pressure is normal, you don't need to do anything about it. You can treat this rhythm with anticholinergics, such as atropine or glycopyrrolate, if you want to increase your blood pressure. Another common rhythm is a sinus bradycardia, which is a slower than normal rate, but with a normal rhythm and complex shape. Again, it's kind of caused by similar things to a sinus arrhythmia, such as an athletic patient, those with a slow metabolism like hypothermia or hypothyroidism. Those with abnormally slow heart conduction, so this can be in sick sinus syndrome or most commonly hyperkalemia. Otherwise high vagal tone, raised intracranial pressure, and then drugs as well. So because there's many different causes of this rhythm, our treatment of it is going to depend on the cause and our blood pressure. So again, if your blood pressure is normal, you don't necessarily need to treat this. But if your blood pressure is low, then you might want to consider it. So commonly under GA, this might be associated with hypothermia, so check your patient's temperature, consider active warming if it's low, and check your patient's potassium, particularly if it's a new sinus bradycardia, and you can treat that as appropriately. Otherwise, if you've just got a sinus bradycardia and the patient is hypotensive, you can treat it as for the sinus arrhythmia with anticholinergics. An AV block is a common rhythm under GA, particularly a second-degree AV block. This is a slower than normal heart rate, and then we divide it into 3 degrees. So a first degree is when you've got a prolonged PR interval. So essentially what you can think of this as is the atria have depolarized normally, but then the depolarization is just taking a little bit longer to get through the atrioventricular node to then depolarize the ventricles. A second degree AV block is when you have some waves conducted through the AV node, but not all of them. So you end up with some P waves that have no QRS complex. The resultant rhythm can be regular or irregular, but they tend to have a normal QRS shape. We can then have third degree AV block, which is essentially a complete block through the atrioventricular node, so no signals from the atria are reaching the ventricles. You get complete dissociation of the P waves from the QRS, so essentially your P waves have their own rate, and then the QRS complexes have their own rate, which is different. The QRS complex shape will depend on where the depolarization is originating. So the closer up the ventricular septum towards the atrioventricular node, you'll have a more normal complex shape, whereas if it's originating somewhere in the ventricles, you might have a taller, wider complex shape, like the bottom right ECG trace. The treatment of this rhythm, again, similar to other bradycardias, if you've got a second degree AV block, which is going to be our most common one we'll see under GA, it can be particularly associated with high vagal tone and use of alpha-2 agonists. In this case, it's a normal physiological response to vasoconstriction. And in this case, if your patient is hypertensive, again, treat it with anticholinergics. If you've got this rhythm in a awake, non-medicated patient, I'd probably recommend cardiac investigation, but not to jump into treatment in this case. So now I'm going to go on to some faster rhythms. So we've got sinus tachycardia, which is a faster than normal rate with a normal rhythm and complex shape. It's many different causes, so particularly stress and anxiety in hospital, exercise, hypermetabolic states like pyrexia or hypothermia. It can be associated with shock, so hypovolemic shock, hemorrhagic shock, dehydration will cause a tachycardia. Otherwise, particularly drugs and toxins, so caffeine, chocolate, alfaxolone, ketamine, anticholinergic drugs and adrenaline will cause a sinus tachycardia. But particularly to note under GA is pain can be associated with this. So if we've got a new sinus tachycardia under GA, we need to consider, is our patient comfortable enough? The treatment of this rhythm will depend on its cause and blood pressure. So if our blood pressure is high, this might indicate that the patient is in pain, too light under anesthetic, stressed, so treat that as appropriately. If our patient is hypotensive with a sinus tachycardia, this indicates that the patient's heart is beating too fast for adequate ventricular filling between cycles. So we might need to increase the patient's circulating blood volume. So we might need to give some fluids or blood products, or else if it's caused by a toxin, we might need to slow down the heart, for example, with atenolol. Atrial fibrillation is a faster than normal rate with irregular rhythm. In this rhythm, we don't see any P waves, but we usually see a normal QRS complex. In our veterinary species, they tend to more get atrial fibrillation, which is the top ECG, where you see an irregular baseline, whereas humans tend to get atrial flutter before they get atrial fibrillation, which is the more jaggedy sawtooth baseline that you see in the bottom ECG. This rhythm in veterinary patients is usually associated with a primary cardiac disease like DCM, and in this case the treatment will include things like defibrillation or antiarrhythmics, but I would definitely recommend basing this treatment first after cardiac investigation, so maybe a heart scan and then a diagnostic ECG. If you've got this rhythm under GA, don't rush into treating it. Check your blood pressure first, and then go from there. If you're concerned your patient is unstable, then it might be worth ending the GA and then investigating from there. A supraventricular arrhythmia is a fast heart rate that originates from above the ventricles, so somewhere in the atria. It has a normal QRS shape, but doesn't have a P for every QRS, but should have a QRS for every P. Again, it often indicates primary cardiac disease, and for example, DCM, as with a little Doberman there. It can occur as a single complex, so like the top ECG, or it can come as a run of supraventricular tachycardia, where you have a fast rate over 200 beats per minute. Again, this should be investigated. If you see these under GA, make sure you check your blood pressure again. Keep an eye on how frequent these complexes are coming. You can consider vagal stimulation, so you can do this by pressing on the eyes, over the eyelids, as well as carotid massage. But otherwise, these often require long-term treatment with antiarrhythmics such as diltiazem. A ventricular premature complex. This differs from the previous rhythm as these complexes originate somewhere in the ventricles, so below the atrioventricular node. With these, you might have a normal or slightly faster heart rate. You have an irregular rhythm. So when you have a P wave, a QRS complex will follow it, but not every QRS has a preceding P wave. On the premature complexes, the shape may be wide and bizarre, but the shape of it depends on where the depolarization is originating. And following the abnormal complex, you'll have a large wide T wave in the opposite direction to the way it normally goes. So you can see the VPC in the middle of the ECG has a taller, wider QRS complex, and then its T wave goes negative under the baseline. These have many different causes. They don't always indicate cardiac disease. They can be associated with systemic illness, so often electrolyte changes, just drug-related under anesthesia, but particularly catecholamines. And yeah, kind of toxins like chocolate and caffeine can cause these. I had a lecturer tell me once, if you've ever had the experience of drinking a few too many coffees late at night, and then you feel in your chest just a that is a VPC. Otherwise, primary cardiac disease like dilated cardiomyopathy or myocarditis can cause this. Whether you need to treat these or not, again, depends on your blood pressure. If you've just got a few, your blood pressure is normal, then you don't need to treat them, and you can continue your GA if you're otherwise happy. If you can see that these complexes are getting more frequent, maybe you've got a few runs of them together, the patient's hypotensive, then this can be a little more serious. And then we get a ventricular tachycardia, which is 3 or more ventricular complexes in a row. With ventricular tachycardia, the faster the rate, the worse the rhythm is. So a true ventricular tachycardia is over 180 beats per minute. This is in a dog. In a cat, we use roughly the same ranges in an anaesthetized patient, but in an awake patient, I tend to say a true VTach in a cat would be over 220. If it's below 180, we call this an accelerated idioventricular rhythm. And the reason we want to differentiate between these two is that an accelerated idioventricular rhythm is more associated with systemic illness. So it can be drug-related, anesthesia, electrolyte abnormalities, and toxins. But we tend to see this rhythm most commonly in our kind of critically ill patients. So those with like a hemangiosarcoma, a GDV, sepsis, just being very unwell in hospital. A VTach is usually a primary cardiac issue, so things like DCM, arrhythmogenic right ventricular cardiomyopathy, which is the new name for Boxer myocardiopathy, which is why he's up there, and severe pulmonic stenosis can also have this rhythm. This rhythm usually does not produce adequate cardiac output, so you need to check your pulse and your blood pressure. If you've got an AIVR, you want to investigate your systemic disease and try and kind of improve their perfusion. So maybe you want to give a fluid bolus. Maybe they need some vasopressors, just kind of to help them cope with their systemic disease. But if you're concerned, like the rate is getting faster, maybe you've got lots of different shapes of your ventricular complexes, the blood pressure is low, you can't feel a pulse, it's all not looking good. We tend to treat these with lidocaine and CPR. So it's really important that if we have this rhythm and you don't think you can feel a pulse, your patient needs you to help its heartbeat. So it needs the compressions first. And then you can get your lidocaine. So in dogs, we use 2 mg per kg, slow. In cats, they might need a lower dose than this, and cats tend to react a bit stronger to antiarrhythmics. So you can start a bit lower and slower. And then ventricular fibrillation has no distinguishing rate, rhythm, or complex shape, no pulse or cardiac output, so start your CPR. If you have a defibrillator, you can use it, but usually we recommend starting with lidocaine. So in a nutshell, if you've got a bradyarrhythmia, check if your patient is warm enough. You might want to check its potassium if it's not new, but often under GA it's drug related, so you can use an anticholinergic if your blood pressure is low. If you have a tachycardia and your complex shape is normal, consider if your patient might be stressed, in pain, having ingested toxins, or if you think it's got atrial disease, do an echo. If you have a wider bizarre QRS complex, try and improve your hemodynamics with fluids, and check for pulses because you might need to do CPR. If you're not certain with your rhythm, just make sure you've checked your pulse and your blood pressure, and then you can always call your local hospital. So we are contactable via our ECC service, or you can contact cardiology for more long-term case advice.